Good morning, everyone. Thank you for joining us today. My name is Dr. Paul Lleva. I'm a vascular neurologist, a practicing neurologist here in Greenwich, Connecticut, and an assistant professor of neurology of Yale School of Medicine. Today, the topic is about stroke, which I entitled Stroke Management in the Heat of COVID-19 Pandemic. As you know, this new strain of virus, SARS-CoV-2, has brought enormous concern globally, affecting the public, healthcare workers, patients, and our economy. It has affected most individuals' behavior and perception of health. For reasons that are unclear, we have noted a marked decline of TIA and stroke presentations in the hospital during the months of March and April, since the very first case of COVID neighboring state, New York. And for reasons that we cannot explain with certainty, the onset of COVID-19 was correlated with a reduction in admissions, particularly that of mild and moderate strokes. This is very concerning, as 1/3 of mild strokes or TIA symptoms can convert into severe disabling stroke if ignored. The human race is once again in a battle to preserve humanity. One thing for sure, we will survive this as we have proven resiliency over the passage of time. Let us begin. I have no disclosure for this talk. One of the clinical dilemmas we are addressing today is the high amount of new stroke cases per year. And in hope of reducing that, one objective of this lecture is to increase familiarity with the clinical manifestation, diagnosis, and management of ischemic stroke. We are also faced with a new dilemma during this pandemic. As some of you may know, we are seeing cases of stroke across various ages in patients infected with SARS-CoV-19. Therefore, another objective of this talk is to increase awareness of the neurological manifestation of SARS-CoV-19 and its potential mechanism leading to stroke. In this course, I will briefly talk about the history, definition, and types of stroke. We will then switch gears and talk about COVID-19, how it is creating a dilemma in stroke management, its potential neurological manifestations, proposed mechanism for stroke. We will focus on the various symptoms and signs of stroke and how to recognize them. Then we will talk about the initial workup to confirm the stroke diagnosis, acute management, and then I will discuss the various ways to help prevent another stroke from happening, and also discuss ways to primarily prevent a stroke. We will then conclude with an open discussion to answer any questions you may have. Overall, this talk will last for approximately 45 minutes. All right, and the father of medicine, Hippocrates, first recognized stroke about 2,400 years ago. At that time, stroke was called an apoplexy, which means struck down by violence in Greek. This was based on the observation that a person develops sudden disabling paralysis and change in overall status. Also at that time, doctors had little knowledge of the anatomy and function of the brain and until in the mid-1600s, when examining dead people became common, a Swiss pathologist, Jacob Weffer, determined that stroke is either bleeding in the brain or blockage in one of the brain's blood vessels. Weffer is remembered for his work involving vascular anatomy of the brain and the study of cerebrovascular disease. He was the first physician to hypothesize that the effects of a stroke were caused by bleeding in the brain. Medical science continued to study the cause, symptoms, and treatment of apoplexy, and finally in 1928, apoplexy was divided into categories based on the cause of the blood vessel problem. And this led to the term stroke or cerebral vascular accident. So there are two types of stroke. About 85% are the ischemic type, which is stroke due to lack of blood flow. The hemorrhagic type represents about 15% of all strokes and is due to rupture of blood vessel resulting to bleeding. Stroke is now often referred to as a brain attack to denote the fact that it is caused by a lack of blood supply to the brain. Very much like a heart attack is caused by a lack of blood supply to the heart. The term brain attack also conveys a more urgent call for immediate action and emergency treatment by the general public. Each year, close to 800,000 people in the United States develop stroke. And to put this into perspective, this is about half of the population of Manhattan in 2017. And about 80% of stroke cases per year are new. This tells us that there is a good chance that we can lower the incidence of stroke if we can identify and modify risk factors. All right, now, the more you are aware about stroke risk factors, the better the chance that you can adjust your lifestyle and hence diminish the chance of developing stroke. Through this educational campaign, we are hoping to meet that goal. So this talk was actually supposed to be given and scheduled for May, as May is National Stroke Awareness Month, but got rescheduled today due to the pandemic. So the National Stroke Awareness Month aims to save lives by increasing awareness and educating the public about cardiovascular health. Hopefully, this educational endeavor will help reduce the incidence of stroke in the United States. So here, one person will have a stroke every 40 seconds. Stroke kills nearly 133,000 people a year here in the United States. It is now, through the endeavors of the American Heart Association and American Stroke Association in improving public awareness, stroke is now ranked 5th from previously the 3rd leading causes of death in the United States after heart disease, cancer, chronic lower respiratory diseases, and accidents. And stroke accounts for 1 of every 20 deaths in the United States and kills someone in the US about every 4 minutes. In fact, at the end of my talk, about 7 people would be dead from stroke. So what is the prognosis after a stroke? About 75% of stroke survivors will have some type of disability, which can range from physical, mental, and emotional. About half of patients will continue to have weakness. 1/3 will need assistance when walking. And almost half will have some cognitive impairment or memory impairment. Close to 1/3 will suffer from depression. About 20% will remain to have language impairment or expressive difficulty. About 1/4 will be dependent on others, and about 1/4 will be institutionalized, such as admission to a nursing home. So the earlier a patient with stroke gets treated, the more brain tissue will be saved. During a stroke, part of the brain where blood flow is interrupted undergoes changes, which is illustrated in this slide. Part of the brain that undergoes changes will show different zones of dysfunction, which is what's shown here. The normal blood flow to the brain runs at a rate of about 40 to 60 ml per 100 amps per minute. Once the flow decreases below that, these zones of dysfunction can form, which is what you see here. First is the infarct core, which is the red zone that you see here. This the part of the brain that is irreversibly damaged. Next is the penumbra, which corresponds to the green zone See here, this is the zone that remains potentially salvageable if blood flow is restored quickly. The region of the brain that we are trying to save. Damage with normal perfusion is not restored in a timely manner. The earlier the blocked vessel is open, the better the outcome will be. So what do you need to do if stroke is suspected? Get to the emergency room right away. The best thing to do is to call 911 and activate EMS. The earlier you reach the emergency room, the better. Because again, time is brain. Every minute that passes, about 1.9 million neurons will die in a typical stroke. Humans have about 22 billion neurons, so you do the math. In fact, an average of 1.2 billion neurons are lost in a typical stroke. So compared with the normal rate of neuron loss in brain aging, the ischemic brain ages by about 3.6 years per hour without treatment and an accumulated 36 years in a typical stroke. Unfortunately, the COVID-19 pandemic has disrupted established care paths all over the world. It is reported through anecdotal studies that governmental limitations imposed on the public, need for physical distancing, public awareness of the pandemic, and the perception of when to seek care for acute conditions have changed. In one tertiary center, the number of cases recorded by the week showed a general increasing trend in 2019 as shown here. In the COVID period in 2020, there was an observed drop in the absolute number of cases per calendar week. Now, this is truly very concerning. We should not ignore even the mildest symptom, and this is best exemplified by this case. We encountered a 41-year-old. She has no known significant past medical history except that she developed flu-like illness 2 weeks prior to presentation and diagnosed to have COVID-19. She self-quarantined at home as her symptoms were mild, which just included muscle pain, cough, and fever. About 1 week after being diagnosed to have COVID, she informed her parents that she felt numb on her right side, which is the face and the arms, but refused to seek further medical attention as she knew that the hospital system was overwhelmed due to pandemic and thought that her symptoms were just mild. The following day, her parents discovered her on the floor in her apartment, unable to talk and unable to move right side of the body. She was then brought to the hospital and found to have a massive stroke involving the entire left cerebral hemisphere, which is the dense white hyperintensity that you see on this image. An MRI showed a blocked left middle cerebral artery, which is what you see here circled in red. She made some recovery, but continued to have language impairment and weakness on right side of the body. So I can never stress this enough, but beware of mild stroke symptoms, that it may get worse. Depending on the cause, about up to 30% of mild stroke symptoms may progress. And as you probably know, this new coronavirus called Severe Acute Respiratory Syndrome, coronavirus 2, began in Wuhan, China in December of 2019 and has led to a pandemic accounting for more than 7.8 million worldwide infections. This has caused more than 431,000 deaths globally as of the second week of June. There are more than 2 million cases in the United States, about 117,000 deaths, and in Connecticut, 44,461 are infected with about 4,146 deaths. Because of the rapid spread of the virus since February this year and the severity of the illness caused by it, public health officials have devised protocols to control further dissemination of SARS-CoV-2. Unfortunately, as a consequence of these efforts, and in part due to social anxiety regarding infection and contact with healthcare providers, there are a number of unintended after effects. As people accommodate to social distancing recommendations by public health and government officials, it was observed that more people avoided healthcare institutions and clinics. More patients resorted to telemedicine, if not telephone evaluations. Many patients have been reported to disregard mild symptoms such as facial droop and numbness. Symptoms of stroke are no longer being recognized quickly. It is then possible that this will lead to a false decline in the overall incidence of stroke and other medical conditions such as myocardial infarction. As reflected by our hospital census back in March, we observed a decline of acute stroke cases by about 40%. Patients with milder stroke symptoms, which could have historically prompted patients to seek medical attention, receive acute treatment and aggressive secondary stroke prevention, may now be minimized to the point that these patients will not present to the emergency room or notify their primary care physician. So what are some of the neurological symptoms of COVID-19? Neurological symptoms can occur in 1/3 of patients with COVID. Dizziness and headache is a common feature, which can occur in 24.8% of cases. Loss of smell, taste, even sight can affect 8.9% of patients. Muscle pain can occur in about 10.7% of cases. So some patients will develop specific conditions such as encephalitis and may present with headache, fatigue, confusion, fever, anosmia or lack of ability to smell. Viral meningitis has been reported, as well as inflammatory conditions such as Guillain-Barré syndrome, which may present with lower limb weakness and numbness or double vision. Acute disseminated post-infectious encephalomyelitis and other autoimmune inflammatory conditions were also observed, which may also present with altered consciousness, unsteadiness, double vision. And of course, another manifestation is stroke, which will be the focus of our discussion today. So, different variety of strokes, including acute ischemic stroke, intracerebral hemorrhage, and cerebral venous sinus thrombosis, have been reported in patients with COVID-19. And one study concluded that 5.7% of patients with severe COVID-19 develop acute cerebrovascular disease, with ischemic strokes being more common than hemorrhagic strokes. And although further data is needed to establish knowledge about this condition, it is proposed that COVID infection causes thickening of blood or causing hypercoagulability. It was also proposed that it can change the configuration of cell receptors, such as depletion of an essential protective receptor called angiotensin converting enzyme. So patients with COVID infection are found to have elevated inflammatory markers, which predispose these patients to clot formation. And to illustrate this process, if you look at the image on the right, COVID-19 is absorbed in the cell by binding of the spikes of the virus to a specific receptor on the cell membrane found in the lung, brain, GI tract, and this is the angiotensin converting enzyme 2 receptor. So COVID-19 decreases or downregulates ACE2 or this receptor, which then leads to unopposed effect of angiotensin, which can lead to blood vessel narrowing, fibrosis, and sodium retention. So the invasion of the cell by the virus also leads to an increase in inflammatory markers such as interleukins, hence the term cytokine storm. This leads to an imbalance in vasodilation, neuroinflammation, oxidative stress, and thrombotic responses, which may contribute to the pathophysiology of stroke during COVID-19 infection. So patients with COVID-19 are presumed to have increased predisposition to develop blood vessel narrowing and clot formation, which can then lead to heart attack and strokes. The pathogenesis of thickening of blood or hypercoagulability caused by COVID-19 is incompletely understood as of this time. Thickening of patient's blood during COVID infection may be thought of in terms of Virchow's triad, which includes endothelial injury, or damage to the inner lining of blood vessel, stasis, or blood flow stagnation and hypercoagulable state. There is evidence of direct invasion of blood vessels by COVID-19, which can lead to cell injury. Other sources of endothelial injury include intravascular catheters and mediators of the acute systemic inflammatory response, such as cytokines, as we discussed earlier, and other acute phase reactants. The contribution of complement-mediated endothelial injury has also been suggested. Stasis occurs when there is immobilization, and this can happen in any hospitalized patients, particularly critically ill patients, regardless whether they have COVID. And hypercoagulable state is also observed, and a number of factors that can cause thickening of blood have been reported or proposed in patients with severe COVID-19. And these patients were noted to have increased levels of factor VIII, fibrinogen, circulating prothrombotic microparticles, neutrophil extracellular traps, and also a hyperviscous plasma. So, can you tell if someone has signs and symptoms of stroke? It is certainly more challenging nowadays due to some of the unintended effects of social distancing and compliance to social reforms, such as wearing facial masks to minimize spread of the virus. What is recommended is the use of this mnemonic, be fast. This may help you identify when someone has had a stroke and needs emergency medical attention. So B stands for balance. Does the person have a sudden loss of balance or coordination? E for eyes, is your loved one experiencing double vision? F stands for face. Does one side of the face droop? A stands for arms. Does one arm drift downward? S stands for speech. Is the person's speech slurred or strange? T stands for time. If you observe any of these signs, call 911 immediately. Again, if you can get the person to the emergency room within an hour of these signs, you can help prevent permanent brain damage, as there are medications that the emergency department can give to dissolve the blood clot in the brain. This is why time is so important when a stroke is suspected. And to understand the stroke symptoms requires understanding of how the brain works. Our brain is supplied by 4 major blood vessels coming from the heart, a pair of arteries in the front, and a pair of arteries in the back. These blood vessels merge inside the skull to provide branches to various parts of the brain. Our body is represented in the brain in a very systematic fashion. The legs are represented in the medial part of the brain, which is what you see here, the moving lateral, the arm, and then the face. If the stroke affects the blood vessel in the middle, so that's the anterior cerebral artery, then some patients may present with sudden onset lack of facial expression, that's a bulia, weakness of the opposite leg, sudden changes in personality. Some patients may suddenly become incontinent or leak urine, and on rare occasions, some patients may not recognize their own body parts, such as the hand. It's called the alien limb phenomenon. So the blood supply to the side or lateral part of the brain is called the middle cerebral artery, which is what you see here. If the dominant brain is involved, and which is usually the left brain in the majority, if not all of the cases, patients may present with sudden onset inability to speak, that's aphasia, inability to perform learned tasks such as driving, playing an instrument, brushing teeth, a phenomenon we call apraxia. Patients may also develop weakness and numbness on the opposite side of the affected brain. Some patients in more severe cases may develop blindness on one side of their visual field. If the non-dominant brain is involved, patients may also present with difficulty performing certain tasks, such as dressing, and some may also develop weakness and numbness on the opposite side of the body, and some may lose their navigational skills. It's a phenomenon we call topograpagnosia. And some may lose the ability to perceive music and would speak like robots due to lack of perception of voice intonation, amyloidia and aprosodia. If the blood vessel at the back part of the brain is affected, that's the posterior cerebral artery, some patients may present with blindness on one side of their visual field. Some may present with difficulty reading, blindness, difficulty recognizing faces even though they can see the face. It's prosopagnosia, and some may lose the ability to perceive colors or color agnosia. If the base of the brain is affected, some patients may develop weakness or numbness on one side of the face and weakness and numbness on the opposite part of the body. Most will present with dizziness and imbalance. So these syndromes that you see here, these are the various manifestations of stroke affecting the posterior circulation, which is what you see here. So how do we confirm the diagnosis of stroke? The diagnosis of stroke is given if clinical findings suggest stroke, as we discussed earlier. Specific clinical symptoms correlating with specific vascular territories in the brain. So stroke diagnosis is ascertained with use of imaging such as a CAT scan and an MRI, which can confirm the presence of brain infarction, which is what you see here. If enough time has lapsed, stroke will appear dark on CAT scan and will appear as bright white lesion on the MRI. So this is a blood vessel imaging of the brain called CT angiogram. Here, where the yellow arrow is pointed, is a blocked blood vessel affecting the blood supply to the left side of the brain, which is a finding supportive of the diagnosis of ischemic stroke. Okay, now let's talk about acute stroke treatment. There are two goals of acute stroke treatment. The immediate goal is to quickly restore blood flow to the regions of the brain that are potentially compromised. And there are two forms of treatment that a stroke patient may get if seen early. And this includes a clot buster called alteplase and a procedure called mechanical thrombectomy. So the long-term goal is to improve outcome by reducing stroke-related disability and mortality. So for those patients who can make it to the ER within 3 hours and within 4.5 hours for those who are less than 80 years old and without known bleeding disorders, history of recent trauma, stroke, alteplase, or IV TPA can be given. It is given in the vein as a bolus and infused over 1 hour. Some stroke patients who received alteplase were observed to have better chances of living without a disability compared to those who did not receive treatment. Any treatment is not without risks. About 6.4% of stroke patients who are given treatment may bleed spontaneously, but it is a risk worth taking if faced with a risk of lifetime disability. So there are cases when alteplase cannot be given. And these cases include patients who had recent head trauma or bleed, patients with known brain tumor, recent bleed in non-compressible sites such as the GI tract or spine. Alteplase is also held in patients with symptoms suggesting bleed in the brain, patients with hard to control blood pressure, such as when the blood pressure remains more than 185/110 despite treatment in the ER, the presence of bleeding disorder, and CAT scan evidence of bleed or extensive infarction. So the presence of any of these risk factors predisposes patients to bleed, which can lead to increased morbidity or death if given a clot buster. So I can't stress enough the importance of early treatment. The earlier the blocked vessel is open, the better the outcome will be. So this graph illustrates that the earlier we give IV TPA, the better the overall outcome is for the patient. And this also shows that after 4.5 hours, the benefit of alteplase is no longer seen. It has been shown in numerous studies that there is a strong correlation between quickly opening up the blocked vessel and the outcome of acute ischemic stroke. Again, the earlier we see the stroke cases in the ER, the better, as it is a time-sensitive management. So due to the COVID pandemic, we have adjusted our protocol in the emergency room to protect patients and responders. Since stroke is a neurological manifestation of COVID, it is recommended that all patients with severe emergent cardiovascular diseases should be managed as suspected cases of COVID-19. The room is thoroughly cleaned and sterilized to minimize spread of the virus. And although alteplase is readily available in the ER to open up blocked arteries, there are limitations to its use. It is often ineffective if large arteries are occluded. Larger clots are just more resistant to the effects of this clot buster, and also less effective in clots made of calcific plaques and fat. It is also dangerous to administer this drug after 4.5 hours due to the risk of hemorrhagic transformation, which is shown here on CT head images. It cannot be given in certain cases, such as patients taking irreversible blood thinners, recent surgery involving non-compressible sites such as the spine, the brain, GI tract. And again, not all blood vessel occlusions can be opened or unclogged by alteplase, particularly those clots that are dense and extensive. Because of this, mechanical thrombectomy is performed for those patients with moderate to severe stroke who present within 6 hours. Mechanical thrombectomy is a procedure manually removing the clot using a mesh wire, such as what you see here. Mechanical thrombectomy or manual extraction of clots can be performed if the damage is not complete yet, which is defined as the infarct not being prominent on CT head, or if the infarct size is less than a third of the projected blood vessel distribution. It is indicated if there is also presence of a large vessel occlusion, which is what you see here, the middle cerebral artery is blocked. So we can treat acute stroke up to 24 hours. 2 trials have shown that with the use of a special imaging called perfusion imaging, salvageable brain tissue can be identified. Opening up blood vessels in strokes with viable brain tissue showed good clinical outcome in close to 50% of patients. And this is what a CT perfusion looks like. The green region you see on the right is the area of the brain threatened, and the purple one on the left is the permanently infarcted brain tissue. So the difference between the two is the salvageable portion called the penumbra. This technology has helped several patients with stroke due to the extended therapeutic window for mechanical thrombectomy. All right, now let's talk about the unwanted results of stroke management. Although there is a good chance for a good outcome after mechanical thrombectomy, not all arterial recanalization can lead to a good outcome. Sometimes we encounter a condition called a no reflow phenomenon, which means the brain tissue supplied by the blood vessel remains without flow due to persistent distal clots and micro occlusions. Occasionally, we would encounter a case where there is no mismatch, meaning there's no salvageable brain tissue left. There are cases where the infarct will be completed early due to poor collateral circulation or poor connection or networking of brain blood vessels. Complications may happen, but uncommon. Opening up a brain blood vessel may also lead to injury in a few cases. So this is called reperfusion injury. It is when an inflammatory reaction leads to loss of integrity of the blood-brain barrier, which can then lead to brain swelling and bleeding. All right, let's look into some of the predictors of stroke outcome. So first is the stroke severity at presentation. This is the most important factor affecting short and long-term outcome. For those who present with severe initial clinical deficit, there's increased chance of disability. Age has a major negative impact on stroke outcome. Younger individuals tend to do better compared to the older counterpart. Presence of medical conditions such as anemia, atrial fibrillation, cancer, heart disease, dementia, diabetes, heart failure, myocardial infarction, severe leukorrhiosis, or increased blood vessel disease burden in the brain, kidney dysfunction, and poor nutritional status have been associated with poor outcome. Findings on neuroimaging can also help predict the outcome. Stroke cases who present with larger and extensive clots, such as patients with occlusion affecting the large arteries, such as the carotid, basilar arteries, have been associated with poor outcome. And some patients will have great collaterals. These are the network of blood vessels that we talked about earlier, supplying the brain. Patients with robust connections usually fare better. And patients who are well-conditioned, non-smokers, tend to have good collaterals. So how can another stroke be prevented? So to prevent a stroke, we have to determine where the clot came from. And based on the current classification of ischemic stroke causes, stroke can arise from the heart, from the large blood vessels in the head and neck, from the small blood vessels of the brain. And however, close to a third of stroke are of the unknown type, and this is what we call cryptogenic. Some strokes have an atypical mechanism, which we call other determined cause of stroke, which represents 5% of the cases. So about 20% of strokes are caused by blockage of the arteries in the neck. So we call this large vessel strokes. As you can see here, cholesterol plaque builds up, causing stenosis or blockage. The plaque can either break off and travel north to the brain. The plaque can also reduce the blood flow to the brain if severe enough. Patients who are deemed to have symptomatic and significant carotid stenosis are usually advised to undergo a surgical procedure called carotid endarterectomy. And for those who are at high risk to undergo surgery, sometimes carotid artery stenting can be performed. Carotid stenosis who are deemed to be asymptomatic or without symptoms are usually followed over time and managed medically. Another source of stroke is the heart. Patients with heart conditions such as atrial fibrillation or irregular heartbeat, patients with severe heart failure can produce a clot in the heart. Again, the clot can get dislodged and travel to the brain. Atrial fibrillation increases stroke risk 5-fold. Patients who are found to have cardioembolic stroke are usually started on anticoagulation when the stroke has stabilized and if there are no medical contraindications to blood thinners to decrease the risk of bleed. Another mechanism for stroke is due to blockage of the small blood vessels in the brain. And this is usually seen in patients who are known to have chronic high blood pressure, diabetes, and those patients with certain blood disorders such as sickle cell anemia, where direct damage to the blood vessel can occur and lead to the thickening of the muscle layer, increased deposition of hyaline and plaque formation. Patients with small vessel stroke are usually started on antiplatelets as well as risk factor modifications such as controlling blood pressure for hypertensive patients and optimizing blood sugar for diabetics. And for the unknown source of stroke type, there are several presumed causes, and this includes migraine, genetic disorders, blood vessel abnormalities, infections, abnormal vitamin levels, sleep apnea, hypercoagulable states such as the proposed mechanism for COVID-19. And those with known blood disorders, certain cardiac conditions such as having a hole in the heart. This is called patent foramen ovale. And the last mechanism is classified as the other determined stroke type. So this includes traumatic insults to the blood vessels of the head and neck, such as development of a dissection. Here you can see how the blood vessel is pulled taut during head turn, and this can potentially lead to vessel rupture during sudden neck rotation. So a big component of stroke prevention is living a healthy lifestyle. This can lower your risk by about 80%. This includes good blood pressure control if you are hypertensive, not smoking, reducing salt intake, lowering cholesterol, weight control, increased physical activity. Regular follow-up with your medical doctor is also key. You should also reduce consumption of red meat and unhealthy diet. The Mediterranean diet is recommended to reduce cardiovascular risk factors. This is a diet that is rich in vegetables, fruits, nuts, fish, which has been reported to have the potential for decreasing risk of stroke by more than half. And for the general population who has never had a stroke, it's important to focus on risk factors that are modifiable. And this includes smoking, weight control, diet, physical activity level, cholesterol, blood pressure, and diabetes management. As mentioned earlier, individuals who select a healthy diet have significantly lower risk of cardiovascular disease. Diet is a silent killer. We should really be mindful of what we eat. Smoking causes a buildup of debris on the inside of blood vessels. It's a condition called atherosclerosis, and it contributes to a higher likelihood of clots forming. Smokers have double the risk of a stroke caused by a dislodged blood clot, ischemic stroke, and 4 times the risk of stroke caused by a ruptured blood vessel or hemorrhagic stroke than the non-smoking population. In addition, smokers have a greater chance of having more complications and recurrent strokes. Patients who have had minor stroke are 10 times more likely to have a major stroke, especially if they continue to smoke. So it is never too late to quit. Treatment of hypertension is also one of the most important interventions for secondary prevention of ischemic stroke or primary prevention of ischemic stroke. Target blood pressure for stroke prevention should be less than 130/80, especially for those who have had a stroke. So most researchers believe that elevated blood cholesterol concentrations are an important risk factor for stroke, especially ischemic stroke. It has been found that lowering the LDL levels can prevent stroke in 35 to 80% of the cases, reducing the risk by 48% in patients with diabetes and 25% in patients with coronary artery disease. So does diabetes put me at an increased risk of heart disease or stroke? Diabetes is definitely a risk factor for heart disease and stroke. It is an independent risk factor for stroke recurrence. If blood sugars remain elevated over time, it affects your body's blood vessels, including all veins and arteries of the body and all the organs of the body. By maintaining your blood sugar, you can decrease the risk of heart disease and stroke as related complications. So physical activity improves stroke risk factors. It reduces stroke risk itself and aid in recovery. It is recommended that one should exercise at least 3 to 4 sessions per week of 40 minutes of moderate to vigorous intensity aerobic physical exercise. So this can include walking at a brisk pace, bicycling, softball, shooting baskets, recreational swimming, yoga, anything that can make you sweat. So patients who are heavy drinkers should eliminate or reduce their consumption of alcohol. Drinking more than 2 alcoholic beverages a day in middle age raises stroke risk in early old age more than the traditional risk factors do, such as high blood pressure and diabetes, as a study suggests. In one study, heavy drinkers, such as those who consume an average of more than 2 drinks per day, had a 34% chance of or increased stroke risk. Another risk factor is sleep apnea. Sleep apnea more than doubles the risk of stroke for middle-aged and older men, and also increases the stroke risk in middle-aged and older women. A sleep study might be considered for patients with an ischemic stroke or TIA. Treatment with CPAP might be considered for patients with ischemic stroke or TIA and sleep apnea. Another question that I often get asked is the use of aspirin. So should I take an aspirin to prevent stroke? Several trials have looked into this, and the studies have shown that aspirin confers a statistically significant and clinically important reduction in the risk of non-fatal MI or heart attack, but no benefit on all-cause mortality of stroke. So for stroke prevention, it should not be used in the routine prevention due to lack of net benefit. All right, in conclusion, early recognition of stroke symptoms can lead to expeditious diagnosis and management and good outcome. Stroke management is a time-sensitive matter. The earlier we treat stroke, the better. Today, there is a wealth of information available on the cause, prevention, risk, and treatment of stroke. And most stroke victims now have a good chance for survival and recovery. Immediate treatment, supportive care, and rehabilitation can all improve the quality of life for stroke victims. Despite the hurdles of this pandemic, I urge the public to not disregard minor stroke symptoms. The hospital is prepared to help you. We are available to help you. So please call 911 if you have a medical emergency, especially stroke symptoms. We have also created a stroke center hotline at Greenwich Hospital. If you need to speak to the on-call neurologist, you can call at 203-863-4600. And there's also an outpatient neurovascular center at 203-863-4490, where a stroke neurologist such as myself and a neurovascular surgeon are available for expert stroke consultations. If you need additional information about stroke, you can access the stroke website at www.strokeassociation.org. Again, thank you for listening and participating in this talk. I am now open to answer some of your questions.
If you have any questions, just use the Q&A feature at the bottom of the screen. The doctor can read them and answer them.
I'm just trying to open up the first question here. Yeah, I'm clicking the Q&A portion now, and it doesn't seem to be opening up. Should I stop sharing?
You can do that.
All right, so the first question I see here coming from Kathy is, can you receive mechanical thrombectomy after receiving TPA? So the answer to that is yes, and it depends on the type of stroke that we're seeing. If the patient comes in within the time frame, so for TPA it's within 4.5 hours, and then if we do find that the patient has a big clot causing blockage of a large vessel, then we normally would proceed with a mechanical thrombectomy. So the answer is yes, if there is a large vessel occlusion causing the stroke. All right, so the next question is, I thought the inclusion period for treatment was increased to 6 hours. Now, so this question came from Liz. Now, is this for TPA or mechanical thrombectomy? So for TPA, the therapeutic window is still up to 4.5 hours. If the patient is 80 years old or younger, we normally, will not give it beyond 4.5 hours because there is no benefit. Although there are studies right now, or there was a study conducted, outside this country, that the TPA period was actually increased up to 9 hours. But we are not ready for that particular protocol yet here in the United States. It has been proven outside the country, but here we still restrict it up to 4.5 hours. Now, to answer the other question, so we have extended mechanical thrombectomy up to 24 hours. So if there is a large vessel occlusion on the imaging, and if there is a salvageable penumbra between 6 and 24 hours, we can open up that artery using this procedure called mechanical thrombectomy, which is manually extracting the clot from the blood vessel. All right, the third question here is, do patients who have recovered from COVID-19 still have increased risk for stroke? And this came from Francis. So we don't know. We don't have specific answers for regarding COVID-19 yet. But what we do know is that the hypercoagulable state can persist. It can persist even if the patient is already asymptomatic. So I guess a safe answer would be yes. The patient is still predisposed of forming clots, because of the persistent elevation of the clotting factors. Now the fourth question now is there a time of the day when strokes occur more frequently? So this came from Marianne. Theoretically, just like heart disease, heart attacks, it commonly happens between 3 a.m. up to 10 in the morning. Now, why is that? What is the reason why there's a increased amount of events early in the morning? And we believe that it's probably has got something to do, with the hormonal, cycle of the body, because our catecholamines. So this includes adrenaline, or norepinephrine. It usually begins to go up, by 3 to 5 a.m. And this has got something to do with our body waking us up. So so one theory is that this catecholamine surge, because of its elevation, then it predisposes our body to be in a hyperadrenergic state, and then which can lead to fluctuation of blood pressure early in the morning. So again, this is just a theoretical answer to that question. All right, please feel free to follow up on your question if you do not feel that I have answered the question. All right, any more questions? All right, well, again, thank you so much for inviting me to give this talk. And if you have any further questions, you can contact our office, our stroke hotline for any issues, and we are here to help you. Thank you so much.